So I'm really delighted to welcome you all today to our visiting professor, Professor Bill Phillips from the University of Washington. He's an emeritus professor there. He is an enormous leading figure in academic and clinical family practice in the United States. He was a founding editor of one of the world's leading primary care journals. He's led lots and lots of projects. So worked in all continents, haven't you? I'm not sure if you've actually practiced in Antarctica, but you probably have.
But I've been there.
So Bill has been working more recently on a framework to look at suffering. So he's going to talk to us about that today. Thank you very much, Bill.
Thank you for that generous introduction, and thank you for the opportunity to be here, the sponsorship and generous support from Trinity College and the General Practice Department, as well as the coalition and the community group as well. And I just want to give a special thank you to the group that's so devoted their way down at the end. Can you hear okay with the microphone set up? Yeah. Okay, I'm told I have to be here for the mic and the camera, so I won't be able to roam as much as I wanted to. The theme today is suffering, so I could probably summarize the whole talk today by adding to what was just read by, say, take time to care. When all is said and done, we're all just walking each other home. I need to know how to get this to advance. It's not. Thank you. Just a little bit of a delay. Okay, I have no disclosures. We do this in the United States, no conflict of interest. I am not financially invested in suffering. Emotionally invested in caring. Here are my objectives. I hope by the end of the session today, all of us will be able to describe multiple ways that suffering manifests in patients' lives. To outline the program, I'll present to you the comprehensive clinical model of suffering as a tool that can be useful for clinical teaching and patient care, and to describe the recognition of suffering as a first step on the pathway of care on the road to healing. Now, we'll hold our questions to the end. Go ahead and type questions, those of you that are online, into the chat if you want to. We'll try to take care of those. Let me apologize ahead of time. I'm an American with a funny accent. So if there's something I say that you just can't understand, raise your hand, because I want us all to be on the same wavelength. But for substantive questions, let them go to the end. And I'd like to start by sharing another American voice about suffering. Suffering's all around us. It's a universal part of the human experience, particularly of the illness experience. Remember, we don't deal just with diseases and organs, but with people and illnesses. The relief of suffering is perhaps the most fundamental obligation of medicine, or so Hippocrates and others early on told us. And for physicians, and I know that's just a subgroup of who we're talking about today, patients bring problems to physicians because it's a socially acceptable, safe place to talk about their worries and suffering. So we have the opportunity as family doctors and other caring professionals to hear patients' problems, their special problems in special ways. Suffering often masquerades as a clinical complaint. When the appointment, a young man comes in and the appointment register says pain in leg, it's almost certainly not about the leg. So for our discussion, distress, injury, and loss lead to suffering when it threatens the meaning of the patient's personal narrative, how they understand themselves to be, their past, their present, and their future. And when that's disrupted, suffering occurs. It arises when a person believes that they can no longer be the person they have known themselves to be. Now, this goes back as a definition to philosophers, medical ethics people like Eric Cassell, but it's a pretty commonly accepted notion how we separate distress from suffering. They often come together, but they're not usually the same thing. Importantly, suffering involves every dimension of a person's life: the physical, the mental, emotional, social, and spiritual. And our task as caregivers or teachers is to comprehend all that in a way that's practical, that you can use day by day in your patient care or in your teaching. I'm interested in this process from suffering, to caring, to healing. There's a lot of scholarship and a lot of talk about healing, rightly so, couldn't be more important. But healing is just part of the process. And the part that's been neglected, I think, and worry is the recognition of suffering and starting with identifying and helping patients manage their suffering. Healing is the whole person process. You hear about holistic healing, which could be defined as the personal experience of the transcendence of suffering. That's kind of a common tagline you use or hear or read in the literature about healing. But you see, it begs this concept of what is suffering. And if there's suffering there, have I found it? Have I helped the patient identify it? Am I doing my job? The path to healing begins with the recognition of suffering. Now, I'm a general practitioner. You're going to use the word family doctor, family physicians, family medicine. That's the term for the same generalist physician specialist that we use in the United States. I might slip into that. General practitioners can help patients navigate suffering, and I think they actually have a special opportunity to do so. It's because they have these long-term continuity relationships. That doesn't exist in all of healthcare. They're there to demonstrate understanding, empathy, and compassion. We hope that exists in all of healthcare, but not everybody has the time or the refined skills to do that, as the GP hopes that she can. We build trust, and we do this all by providing care to the patient over time, from visit to visit and across problems. Nobody but the GP actually has the opportunity or obligation to do that. Bring a variety of problems in at a variety of stages of their development over time, and it's the job of the GP to help negotiate that problem and provide care and get to that healing result if possible. Even just the listening is part of the caring. All suffering is lonely. It's an individual experience. And maybe the first task we have is to let the suffering patient or person believe that it's shareable. It doesn't always have to be by themselves. Other people can understand it. And even though I don't understand your suffering in the first discussion or on the first visit, I'm available to hear about it, and I'm with you. I'm with you. Now, before I go too far down talking about general practitioners, family doctors, patients, I want to emphasize that that's just a microcosm, just a feature of the process, and maybe not the biggest feature in our lives or in our families or societies. So we start with a patient. Before patients bring their problems to the doctor, they're almost always dealt with their family group as they regard it to be. And then it gets to the clinician. That could be a doctor, a nurse, a physical therapist, a counselor, a variety of people, or other helping professionals we'll get to. And even those people, when they're working on a problem and identifying suffering, have a team around them. They're surrounded by a team. The care that I provide and you provide in the exam room isn't confined. Maybe the conversation and the confidentiality and that first few difficult bits of discussion occur, especially in that room. But the care goes way beyond that room. You have team members that are present, team members that are further out from my facility, and in fact, community resources. And I'm guessing that as the third age group has listened to other speakers, you've learned more and more about the needs and the resources that are available in the community that interface with health. So what do we currently know about suffering? Well, first of all, if you look at literature and say, where is the picture I can use to understand suffering as I sit with a patient or as I sit with student nurses that teach them about suffering, such a model doesn't really exist. And that was our first marching orders. If you go to the scholarship to learn about it, there's lots of work, but it's scattered all over in many professions and specialties and disciplines. So it's not easy for a busy student or a busy practitioner to put that together. I can also share with you that in our experience working with trainee doctors in several universities in the United States, the students tell us they don't get much education suffering. They don't get much training. They don't see it modeled for their own wards very much. I learned yesterday working with some first-year registrars in general practice that things might be a lot better here, but still, this is not suffering. It's identification management. It's not what most medical trainees spend most of their day doing. They're busy doing lots of other important stuff and learning how to do other parts of their job. This is an image of the kind of places one would find if you did a comprehensive literature search on suffering. The good material you want to know about is scattered over these places. Look how varied and wide-ranging that list is. It's too surprising that you'd be challenged to make that list up just on a piece of paper. So our goal was to create a new comprehensive clinical model of suffering that recognizes that suffering involves every aspect of a patient's life, as we said, that synthesizes this wide-ranging scholarship, and that uses a family medicine general practice generalist approach. And the keys to that are probably these items: patient-oriented care, comprehensive whole person care, and the generalist perspective. If we're trying to deal with the universal human experience of suffering, and the scholarship and wisdom is scattered over such a wide variety of academic and professional fields, the generalist perspective should provide some special power. So here's what we have to share with you. We won't spend a lot of time exactly on the big wheel here, but you see it's an octagon, so it's got several elements, and we'll go through each level in a minute. This is what we call the comprehensive model of patient suffering. We'll talk more about the details of how it's been used and how it might be used in the future. So first, it's organized on these four axes. We go from the outside to the inside. And the biomedical, the sociocultural, existential, and the psychobehavioral. Now, being just a doctor, I put biomedical at the top because we're most comfortable dealing with symptoms and functions. But that doesn't have to be. You can just rotate this thing. And if you're a mental health professional, you'd probably come in through the psychobehavioral axis and deal with emotions or thoughts. If you were a psychoanalyst or a hospital chaplain or a spiritual director, you'd probably come in through the existential window, and you can choose to put that on top. Physical therapists, occupational therapists, social workers that deal more with the practical functions in life would come into the sociocultural. So I apologize for putting biomedical at the top, but something has to be at the top. Then if we dive in, the most functional part of this are these 8 dimensions: symptoms, functions under biomedical, roles and relationships, worldview and personal narrative, thoughts and emotions. Now, there's lumpers and splitters, and you could ask, where does this part fit? And I got to come up with a place. Well, you can see he's left this out. And so, well, no, it probably fits in there. But this is a more comprehensive model than others that have been written about and taught about. And we think it's more applicable then to the general practice of medicine and the other helping professions. And remember always that at the center is the patient. And almost all the work on suffering, this can come from those different fields we saw on that word cloud side. It could be addiction, it could be psychiatry, it could be rehabilitation with spinal cord, it could be any kind of injury or trouble. Patients at the level of suffering will start talking about not just the distress, but the loss of function or the threat of loss, ultimately leading to despair and sense of isolation. That's why simply talking about these things helps patient. It's maybe the first opportunity to see they're not totally alone, not totally isolated. That's why group therapy sessions or just group support sessions can often help. But the patient's always at the center. Now, to make that a little more concrete, let's look at this for a little bit. We've got the axes, they're the most abstract. The domains are what we can use, I think, clinically to remind us what questions to ask. But what's actually at stake here? For symptoms, you're going to lose or have a threat of loss of comfort. So that's pain, nausea, insomnia, and so on. That's pretty obvious. We've all experienced those in our friends and family and our patients. Functions, the loss is the ability to do what? Loss of ability, of self-care, sleep, self-control. Or under roles, it's the loss or threat of loss of performance. I can no longer be a worker, caregiver, a provider, protector. I think just with these highlight words that are more concrete, you can probably imagine in yourself or a patient you see or a family member, people that are suffering because of loss or the threat of loss of these roles. But the relationships would be family, friend, colleague, lover. We could make each of these lists longer. And the list would be different for everybody because suffering is always an individual experience. So thoughts and emotions aren't exactly the same, so we split them up. One can have emotional loss and threat, fear, anger, sadness, loneliness is a huge one. Grief is one that's almost always at the top of people's list when they are talking about suffering. But there's also intrusive thoughts like anxiety, depression, loss, hopelessness. Now, the existential gets a little bit more difficult because it's pinned upon the patient's own existential framework. Are they a person of a very clearly defined faith? The person who finds the organization of their life in a different realm? That's something you have to get to know a patient. That doesn't mean it isn't important to many patients. So for the narrative, it's a sense of wholeness and meaning and identity. What are their expectations of their future? How will they come to a level of acceptance with their current problem or their threat of loss? What's their sense of future? And worldview has more, that's kind of code word for spiritual view. So that we can alienate some people who might think that was perhaps less appropriate in this realm. So spiritual distress, conflicts in values, conflicts with traditions. See this multicultural, multi-generational families. There's so much distance between the parents, the grandparents, and the kids. There's a lot of distress. Actually, I just describing this topic to somebody, I said, "Oh, I'm going to go give a talk on suffering." And they said, "Oh, families. There's so much suffering in families." And the exact same thing happened in a different conversation where he said, "I'm going to do a course on suffering." "Oh, yeah, marriage." There's so much suffering in marriage. So what it told me really is, and if I talk to my psychologist friends, they say, "Oh, you need more over on that psychobehavioral part of it." And social workers say, "No, roles and relationships, that's where the action is." So it gives me the hint that this octagon, this wheel with 8 dimensions, actually is getting to the right things, and everybody wants more of it. Everybody wants more of it to help with their practice. What a good place to be, and what a good place to be a jumping off point. So the worldview might involve conflicts and perceptions or values or guilt. I talk mostly about patients and doctors, but this certainly applies to any of the helping professions. And it would be an interesting hour just to talk about which are the helping professions and how well are they doing. I mean, we're talking about counselors and physical therapists, but we're talking about teachers and pastors, and you can raise your hands and we can have a great conversation. There's actually this concept that I've always used since I was in my interview training of the helping interview. If you think about taking a history and physical or an intake, I always noticed the social workers talking about, we're going to do our intake. That sounds like some kind of form, and now it's got to be on a computer because it's a form. But really, it's an interview. And if on some level of scale and genuine curiosity, the interaction, the interview itself is a helping thing to most patients. And it makes you feel good about your work. So I like to think about the helping professions and the helping interview, although you'll see me go back to general practice because that's who most of the audiences are for my talk. This is one person's instinct. Think of all two possibilities here. Think of not just the suffering that occurs in families, but the resource and the caring and the attention to suffering that can occur in a marriage or in a family. In fact, that might be a reasonable definition for a family. This is especially true in an intergenerational group, where there's intergenerational trauma, which is a big topic in the United States, I'm sure in every country and here. And the responsibilities we take on in our families, especially if you're caring for kids or older parents or grandkids or other people that are displaced and connected to you mostly by family. Again, it's a matter of people in marriages and families dealing with suffering and care, aiming towards, in a sense, of healing. This is what doctors and patients do before they really talk. The patient comes in with a complaint to the GP or the chosen specialist, or it could be any other healthcare professional with this question in mind. I sure hope you treat what I have. And she probably doesn't know what she has at that point. And the doctor, especially if they're a specialist, says, I sure hope you have what I treat. And that's the dance that really goes on even before anything is asked. So in a way, I think of learning interview techniques or using a model of suffering as ways to help these two people come together sooner, more effectively, getting on the wavelength of I provide what you need. To do that, what helps me most is to understand as soon as possible what it is you need as a patient. So here's an outline that you could use for that interaction, that patient-clinician encounter. And it's kind of got a working process here, kind of an agenda. It's got a parallelism between what the clinician does and what the patient does. So that's what I really want to get across. For the patient, you really need to know what it is you're there for, at least the best you can. You're not really there to, sometimes you're there just to get your form filled out. That's okay. But you're not there for a pain in your leg. You're there for something else. And the best you can do to articulate what's really troubling and worrying you, what might be the cause of your suffering, the better you can do that, the more likely you're going to get the help you need up front. Everybody wants to avoid the doorknob question, we call it in North America. That is, the lady comes in to get her asthma medicine refill, and it's a nice visit, and everything's fine, no troubles. And then as the doctor is going up and putting her handle on the doorknob, the patient asks, oh, what about my husband's drinking? It's the most important part of the visit. It's the most important opportunity to get into what the patient needs and provide her some assistance. And the problem is it came up at the wrong time. So a lot of these strategies and the strategy of patient-centered care is move that up. And here's the way we do that. So the patient needs to prioritize the concerns. That might involve talking to your family or others at home. Make your list. Don't make it off the internet. Make it off of what's troubling you the most. And then when you get there, give the list to the doctor or even to the nurse before the doctor comes in. The sooner the doctor has the list in hand, the more likely they are going to be to prioritize your agenda with their agenda, create a visit that's going to get more done than needs to be done. On the other side, the clinician has got to orient themselves to the visit. It's just a chronic disease management visit. Is this a prevention visit? Is this a sprained ankle visit? Is this visit connected with that letter that the husband sent me 2 weeks ago with the special worries about his wife? Got to get that in mind for the medical record before walking the door. And you get that list in hand and review the patient's list of questions. So now you're starting to come together. Of course, the doctor has her own priorities too. Maybe you mentioned chest pain, but now she's obligated to do a handful of things that she always has to do with chest pain, or a preventive visit, or something else. So finally, you get down here to the negotiation of a shared agenda for the visit. The sooner you get to that, with both your priorities represented on the list, the more likely you are to move forward with a positive visit and to get to these more important underlying questions. Then, after that clinical encounter advances, the patient needs to ask what questions she has, don't leave questions for later, and check on understanding. If she doesn't get something, she's got to figure it out, and that's her chance to figure it out. At the same time, the doctor's given a plan or talked about a prescription or something else, and it's an opportunity for the doctors to have a feedback and say, tell me what you understand we just talked about, or now how we can take the medicine to make sure you really understand things both ways. There's so much rush, so much jargon, and so much room for confusion that check with each other is really important. And then finally, develop a plan. Well, if the doctor makes a plan that isn't going to fly, that's not helpful. And if the patient doesn't understand what the doctor wants, that's not very helpful. So you want to commit to a realistic plan. So that's the way to orchestrate the optimum patient-clinician visit. And if suffering or pain or unexplained problems are likely to be here, then I think that a script, several scripts, including this new model of suffering, can help us get through this more efficiently and more comprehensively so we don't drop the ball and miss things. Now, William Osler is an interesting guy because he's really Canadian who spent most of his career in England and then retired in the United States, and the Americans always like to claim him. But he's famous for saying interesting things like, if you listen carefully enough, the patient will tell you the diagnosis. Every medical student hears that. The problem is we don't have long enough. Not just because things race through in our pace of practice, but because there's one thing and it takes out of enough time. So it's a shared agenda between the patients and the clinicians to say, how can we make this process work more smoothly to get to the real meat of the health? And if suffering's there, I can tell you, that's the meat of the problem. So here's another look with some nice color coding of our model. And I just want to make it concrete again by suggesting that there's some specific questions we can ask or be prepared to answer as patients. Every medical student in the world learns somewhere like their first clinical year, the review of systems. We've all got it in our mind. You can say it in your sleep, and patients heard it again and again. Do you have any headache? Any trouble with your vision? Nausea, vomiting, constipation, diarrhea? When was your last period? Blah, 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 blah. You just rattle it right off. And it's useful. It's particularly useful in circumstances where things aren't clear. It's not clear to the doctor what to do next. But I suggest to you that if we thought about using a review of suffering, still ROS, review of systems, now review of suffering, then it's more likely to actually get to the most essential stuff that we deal with in each visit. So here's just some examples. The symptoms are used to, what causes the most distress? Functions. Does problem keep it from doing? Relationships. Is your problem impacting your marriage, your parenting, friendships? You can go through the rest of these. I don't need to go, but it's a simple question. It's just as simple as, how about any nausea, vomiting, diarrhea? What's diarrhea, doctor? Even on this existential stuff, is something here disrupting some of your beliefs, changing what you expect out of life? I tell you, that's a high yield question for me, what you expect out of life. Now, like everything else in primary care family medicine, this is a big agenda. You're not going to do it in 10 or 15 or 20 minutes. especially when the patient's got several problems and things really need to be taken care of. They really do need a new prescription for their asthma medicine. So just following the pace and principles of general practice, you don't need to do it all in one visit. You probably don't need to ask these 8 questions, but maybe you ought to ask a few. If you're not getting anywhere, you ought to ask a few more. And if you're still stumped, the patient's still got a problem that's not getting better as soon as you expect, or seems to have symptoms out of proportion to the problem you diagnosed, this is a list you can go back to and use to think about, just like the doctor goes back to the review system. It says, maybe I haven't thought about the gastrointestinal system enough. Let's go back to nausea, vomiting, diarrhea. Let me just leave it here for a minute and look at it from the patient's point of view, the doctor's point of view. This is a list of the appointments I'm going to see today as a GP. And this list could be the GP anywhere in the world. Maybe if I don't do little kids in my practice, I'm not going to see the 4-year-old with the ear infection. But just look at these and imagine which ones alert you to the possibility of significant suffering beyond just the problems. What does vaginal bleeding mean to a 23-year-old woman who's 10 weeks pregnant? That's suffering. Why is dad bringing the baby to the background? Could be a simple answer. It's not the typical thing. It should make you curious. And if you're curious, you might ask some special questions. I imagine each of you can come up with a couple others that seem to you to have mean something more than just a diagnosis and a prescription. I'm also concerned that that family medicine, general practice, takes on all comers, all patients, all problems, all stages of disease, and helps identify and manage them. They treat most of it, they refer some of it, they get help from community organizations for a lot of it. So we're prepared to take on anything. But more and more, I think, our society and our population bring to us problems that are even more likely to involve deep suffering. Think of these diseases of despair that are now epidemic in our Western societies. Depression, suicide, alcohol and other substance abuse, loneliness. I have a colleague who's just done a big study on lonely old men and how sick they are. Lifestyle disorders, the teenager on the couch, whatever lifestyle disorder. And for the last one, who can answer what's the most common cause of death in American children after age 1? Gunshot wounds, being shot to death. What in the hell is wrong with that? If that's the world we live in, and there's just every one of these diagnoses and a few others you might choose to put on that, domestic violence, etc., just full of suffering. And if we're going to deal with these problems, we want to get good at dealing with suffering. And the first step is identifying it. Now, again, I think patients and caregivers and patients and caregivers and doctors share some goals in identifying suffering. We want to identify the needs and address the underlying problems and get to what's going to help the patient. We want to do that as quickly, as kindly, as effectively as possible. There's process and relationship involved. We've got time to do it. We don't have to do it all at once. Our goal is to pursue meaningful needs. It's not just a protocol of questions and check boxes. It's to use these questions in an authentic ability to say, oh, tell me more about that. The goal is to understand the patient and illness, not the organ of the disease, although that's sometimes important too, and that's the doctor's job. But if they prematurely dive into organs, dysfunctions, and diseases, they're more likely to miss these bigger pictures, which are often essential to the patient really getting the care they need and the healing they deserve. Now, we've actually got some use of this model in different places. Here's kind of a bingo card of places it's actually been used. Some of them are obvious, end-of-life care, pediatrics, chaplaincy, hospital chaplaincy, addiction. So I want to fill out this card. And if anybody here is interested in trying to use this model, either for patient care or for teaching purposes in new ways. I'm really eager to hear about that. Those of us who are involved professionally and spiritually in general practice and family medicine can see a lot of parallels, that this model of suffering is really close to the part of family medicine. Here are the other themes that we talk about a lot in family medicine. And there's people in this room, I'm sure, that are really experts and devoted to each of these. I just want to acknowledge that they're connected. Patient-centered care, patient-centered outcomes, goal-oriented care, whole person care, and narrative medicine. Each one of those is a subculture, perhaps a cult. They each have their own ethic and literature, scholarship, and people practice these as ways to be better doctors and help patients get better care. I put these in just to refer to them, and we'll share these slides later. Patient-centered care is probably, for the last 40 years, has been the intellectual and spiritual theme of family medicine. Whole person care, this speaks to us all in terms similar to what we talk about with suffering. Spirit, self, inner body relationships. You can see how they parallel. Goal-oriented care is a very interesting one I can suggest to people because it's got a doctor piece of it and a patient piece of it. This is especially particular for older patients as they age, and the goals they have for care might not be the same as the goals the doctor has for them. A caveat here is I'm just an American. The people who developed this are all English speakers. We're together in a culture that's getting more and more diverse, both here in Ireland and at home in Seattle. But this could really be different if we took a different approach from one of these different faith traditions or a different culture or different language. So I'm open-minded to that. I'm also eager to hear from anybody who'd like to explore that with these different contexts. Context is everything. Okay, everyone wants to know how do you do this in 15 minutes? Well, how do you do anything in general practice in 15 minutes? Because it's all way too much work to do. I've already said it doesn't have to all be done at the same time. It's done in context where you can start fresh with every patient. Well, we do have some new patients. I actually think there's a potential positive there. If you were to sit at the coffee table at the end of the day with a bunch of family doctors, which in my city, we can't do anymore because the administration got rid of the coffee table. Where's the revenue generated by the coffee table? So here's what you see. Almost universally, they say this, this is a correct quotation. The system would just not allow me to be the family doctor I know I can be. The doctor I want to be, the doctor I'm prepared to be, the doctor I'm trained to be. I just couldn't do my best work. That's driving them crazy. The term for it is moral distress. Doctors go home at the end of the day feeling guilty that they couldn't do their best work, even though the reason they couldn't is not their fault. It's the fault of the immediate system, the hospital system, the healthcare system, or the bigger society system. And we got problems in the U.S. that are worse than anything you want to complain about. Buy me a beer, I'll tell you about it. The hospital administrators like to call it, well, those doctors need to be more resilient. Yeah, great. Try to find people that are more resilient than people get through medical training and residency. The answer is system reform. And we can't have system reform without some kind of authentic patient partnership. So just be aware that if you're not getting what you want from the medical care system, the doctors aren't getting what they want from it either. They want to do a better job of taking care of you. There's got to be some way to get closer to it. Perceived time with the doctor, that the amount of time a patient perceives the doctor spent with them is directly related to satisfaction. These are data support statements. Clinical scripts, like using review of systems or review of suffering or the model, can create a visit that actually delivers more care, more process in less time. It's more efficient. If you have more content in the encounter, you get more fulfillment in the patient care. The patient was happy with the visit, and the doctor was happy with the visit when they go home at the end of the day. That translates into professional fulfillment and decreased burnout. And there's actually some evidence that if you organize the care, this is not by instilling more time into it, just by organizing the care differently with scripts and other techniques, you actually get an improved experience of care. I felt I was more understood. I felt I got better care. And on the doctor side, I felt I was a better doctor and I met the patient's needs closer to what I would aspire to do. And there's suggested evidence that if that's true, it actually improves the patient's health outcomes. And that's what we're talking about here. So the process is the recognition of suffering, whole person care, and eventually healing. Healing is a different talk. Caring is a different talk too. But the knowledge about caring is a stage that I really want to investigate. The way to investigate it is to have a conversation with all of you in the room. Not by reading the literature that's scattered like we just demonstrated. I did a big study on how doctors are satisfied with their life and how they see healing. And this is the quote that was pretty representative that really stuck out with me. One family doctor said, "I see healing in my patients, and sometimes even have the privilege of contributing to the healing process." They know that healing and caring is bigger than doctor visits. It involves family, it involves culture, it involves the community. But they want to have a piece in it. They work real hard at having a piece in it, and they're looking for techniques to be even better and to work in a system that allows them to do that. Another exciting thing to do with a model like this is to say, wow, this isn't all just the negative stuff. We're talking about suffering, but medical care is not just about suffering. It's about strengths too. So every one of those dimensions we talked about, all 8 of them, we see as strengths. Your roles, the roles you fill in life. Is your suffering preventing you from doing that? Or is that actually a great strength of yours? Is that a matter of pride and resilience? So we can take this model, and I put it here on my slide so we get another dimension and actually assess a person and their situation by the resources and the strengths they bring to them. And that may be the same kind of dimensions as we talked about. Now, after all of this talk on suffering and an initial musical interlude to set it up, I wanted to end with a more positive note. By the way, thank you for spending your summer, these 3 days, your summer here with me. Thank you very much.
It was wonderful. We've got time for questions if anyone has